Anxiety disorders. Anxiety versus fear. Anxiety is defined as apprehension over an anticipated problem. Fear is a reaction to immediate danger. Both involve physiological arousal. Sympathetic nervous system, both can be adaptive. Fear triggers flight or fight, may save life. Anxiety increases preparedness. Moderate levels improve performance. Nature of anxiety, fear, and panic. Panic attacks, abrupt experience of intense fear. Symptoms, palpitations, chest pain, dizziness, labored breathing. Anxiety disorders, most common psychiatric disorder. 28% report anxiety symptom. Most common are phobias. General criteria, symptoms must interfere with important areas of functioning or cause marked distress. Symptoms are not caused by a drug or a medical condition. The fears and anxieties are distinct from the symptoms of another anxiety disorder. Specific phobia. Marked and disproportionate fear consistently triggered by specific objects or situations. The object or situation is avoided or else endured with intense anxiety. Symptoms persist for at least 6 months. Social anxiety disorder, persistent and realistically intense fear of social situations that involves being scrutinized by or even just exposed to unfamiliar people. Symptoms persist for at least 6 months. Panic disorder, recurrent and uncued panic attacks, at least 1 month of concern about the possibility of more attacks, worry about the consequences of an attack, or maladaptive behavioral changes because of the attacks. Panic attacks uncued occurred unexpectedly without warning. Cued, triggered by specific situation. Panic attack is a sudden attack of intense apprehension, terror, and feelings of impending doom accompanied by at least 4 other symptoms. Physical symptoms, labored breathing, heart palpitations, nausea, upset stomach, chest pain, feelings of choking and smothering, dizziness, lightheadedness, sweating, chills, heat sensations, and trembling. Other symptoms include depersonalization, derealization, agoraphobia, Greek agora meaning marketplace, anxiety about situations are those that are difficult to escape from, such as trains, bridges, or long road trips. Symptoms last at least 6 months. Generalized anxiety disorder, worry refers to the cognitive tendency to chew on a problem and to be unable to let go of it. They worry about relationships, health, finances, and daily hassles. GAD typically begins in adolescence. Comorbidity of anxiety disorders. 3/4 of those anxiety disorder meet criteria for another disorder. 60% meet criteria for major depression. Other disorders commonly comorbid with anxiety. Substance abuse, personality disorders, medical disorders. Give an example, coronary heart diseases. Gender and sociocultural factors in the anxiety disorders. Gender. Women are at least twice as likely as men to be diagnosed with an anxiety disorder. Possible explanations. Women may be more likely to report their symptoms. Women are much more likely than men to be sexually assaulted during childhood and adulthood. Women show more biological reactivity to stress than do men. Sociocultural factors. Focus of these problems appears to vary by culture. Dajin-kyo Fusho, Japan, Kayakangst, North America and Greenland, Shenkui, South and East Asia. Factors that may increase for more than one anxiety disorder. Risk factors, genetic. Twin studies, 20 to 40% for specific phobia, social anxiety disorder, GAD, and PTSD. About 50% for panic disorder. Genres may elevate risk for several different types of anxiety disorder. Neurobiological, fear circuit activity, amygdala active, medial prefrontal cortex less active, neurotransmitters, serotonin, GABA, poor functioning. Norepinephrine higher than normal. Psychological contributions, food, anxiety, psychic reaction to danger, reactivation of infantile fear situation, behaviorist, classical and operant conditioning modeling, integrated psychological model, early experiences and perceptions, controllability, dangerousness, parental actions modeling, associations or cues to stimuli. Social contributions, biological vulnerabilities triggered by stressful life events. familial, interpersonal, occupational, educational, an integrated model, triple vulnerability, generalized biological vulnerability, diathesis, generalized psychological vulnerability, beliefs or perceptions, specific psychological vulnerability, learning or modeling, cognitive factors, sustained negative beliefs about the future. People with anxiety disorders often report believing that bad things are likely to happen. Perceive control. People who think that they lack control over their environment appear to be at greater risk for a broad range of anxiety disorders than people who do not have that belief. Attention to signs of threat. People with anxiety disorders have been found to pay more attention to negative cues in their environment than do people without anxiety disorders. Personality, behavioral inhibition. A tendency to become agitated and cry when faced with novel or unfamiliar settings. Strong predictor of anxiety in childhood and social anxiety disorder in adolescence. Observed in infants as young as 4 months old, may be inherited. Neuroticism, tendency to react to events with greater than average negative effect. Linked to anxiety and depression, twice as likely to develop an anxiety disorder. Other etiological factors, etiology of GAD, GABA system deficit, worry reinforcing because it distracts from negative emotions and images, allows avoidance of more emotions. Not disturbance, disturbing emotions, distress of previous trauma. Avoidance prevents extinction of underlying anxiety, individuals with GAD less able to identify their own negative feelings. Etiology of social phobia. Conditioning, Mohrer's two-factor model. One, through classical conditioning, a person learns to feel a neutral stimulus, the CS, that is paired with an intrinsically aversive stimulus, the UCS. 2. Through operant conditioning, a person gains relief by avoiding the CS. This avoidant response is maintained because it is reinforcing. It reduces fear. Etiology of panic, neurobiological factors, locus ceruleus, major source of norepinephrine, a trigger for nervous activity. Interoceptive conditioning, classical conditioning of panic in response to bodily sensations. People with the panic disorder sustain classically conditioned fears longer. Cognitive factors, lack of perceived control can trigger panic. Fear of bodily changes. Etiology of agoraphobia, fear hypothesis, expectations about the catastrophic consequences of experiencing anxiety in public after a panic attack. Psychological treatment, cognitive approaches, increase belief in ability to cope with the anxiety trigger, challenge expectations about cognitive outcomes, psychological treatment for phobia and social anxiety disorder, exposure, role-playing or small group interaction, social skills training, reducing safety behaviors, in vivo exposure, real-life exposure, systematic desensitization, psychological treatment for panic disorder, panic control therapy, exposure to somatic sensations associated with panic attack in a safe setting, increased heart rate, rapid breathing, dizziness. Use of coping strategies to control symptoms, relaxation, deep breathing, psychological treatment of agoraphobia, systematic exposure to feared situations, self-guided treatment, psychological treatment of generalized anxiety disorder, relaxation training, cognitive behavioral methods, challenge and modify negative thoughts, increase ability to tolerate uncertainty, worry only during scheduled times, focus on present moment. Obsessive compulsive and trauma-related disorders, clinical description and epidemiology of obsessive compulsive disorders and related disorders. Obsessive compulsive disorder. 1. Obsessions are intrusive and recurring thoughts, images, or impulses that are persistent and uncontrollable. 2. Compulsions are repetitive, clearly excessive behaviors or mental acts that the person feels driven to perform to reduce the anxiety. 3. Tends to begin either before age 10 or else in late adolescence, early adulthood. 4. Described in childhood as young as age 2. 5th, slightly more common among women than men. 6. OCD is a chronic disorder. 7. Comorbid with anxiety disorders, major depression, substance abuse, hoarding. Commonly reported compulsions include the following. 1. Pursuing cleanliness and orderliness, sometimes through elaborate rituals. 2. Performing repetitive, magically protective acts such as counting or touching a body part. 3. Repetitive checking to ensure that certain acts are carried out. Body dysmorphic disorder. 1. Preoccupied with an imagined or exaggerated defect in their appearance. 2. Women tend to focus on their skin, hips, breasts, and legs. 3. Men are more likely to focus on their height, penis size, or body hair. 4. On average, people with BDD think about their appearance for 3 to 8 hours per day. Often experience high levels of shame, anxiety, and depression about their appearance. About 40% of people with the disorder are unable to work. Slightly more often in women than in men, but often among women it is relatively rare, with a prevalence of less than 2%. Typically begins in late adolescence. Case reports from around the world suggest that the symptoms and outcomes of BDD are similar across cultures. The body part that becomes a focus of concern sometimes differs by culture. Comorbid disorders include major depressive disorder, social anxiety disorder, obsessive compulsive disorder, substance use disorders, and personality disorders. Hoarding disorder. 1. For people with hoarding disorder, the need to acquire is only part of the problem. 2. The bigger problem is that they abhor parting with their objects. 3. Collections of clothes, tools, or antiques may be gathered along with old containers, bottle caps, and sandwich wrappers. Hoarding sometimes led to extremely filthy homes for about a third of people, characterized by overpowering odors from rotten food or feces. More than 40% had accumulated so many items that they were no longer able to use their refrigerator, kitchen sink, or bathtub, and about 10% were unable to use their toilet. 3/4 of people with hoarding disorder engage in excessive buying, and many are unable to work. Although hoarding is more common among men than among women, very few men seek treatment. Hoarding behavior usually begins in childhood or early adolescence, comorbid with OCD, depression, generalized anxiety disorder, and social phobia. Trichotillomania, hair pulling disorder. Recurrent pulling out of one's hair resulting in hair loss, repeated attempts to decrease or stop hair pulling. It may be triggered by feelings of anxiety or boredom, may be preceded by an increasing sense of tension, then may lead to gratification, pleasure, or a sense of relief when the hair is pulled out. Excoriation, skin picking disorder. Recurrent skin picking resulting in skin lesions. Repeated attempts to decrease or stop skin picking. Skin picking may be triggered by feelings of anxiety or boredom, may be preceded by an increased sense of tension, either immediately before picking the skin or when attempting to resist the urge to pick, and may lead to gratification, pleasure, or a sense of relief when the skin or scab has been picked. Psychological treatment of OCD and related disorders, exposure and response prevention, OCD. People expose themselves to situations that elicit the compulsive act and then refrain from performing the compulsive ritual. BDD, provide exposure to the most feared activities. Clients are asked to avoid the activities they use to reassure themselves about their appearance, such as looking in mirrors and other reflective surfaces. Hoarding disorder, exposure getting rid of their objects. Trauma-related disorders, post-traumatic stress disorder, extreme response to severe stressor, anxiety, avoidance of stimuli associated with trauma, emotional numbing, exposure to a traumatic event that involves actual or threatened death or injury. Trauma leads to intense fear of helplessness. Symptoms present for more than a month. 4 major categories. 1. Intrusively re-experiencing the traumatic event. 2. Avoidance of stimuli associated with the event. 3. Mood and cognitive change after the trauma. 4. Increased arousal and reactivity. Once PTSD develops, symptoms are relatively chronic. Suicidal thoughts are common. DSM-IV-TR and DSM-5 in PTSD. DSM-IV-TR. 1 person experienced intense emotion at the time of the trauma. 2. Exposure to media accounts. 3. Difficulty concentrating, difficulty sleeping, and diminished interest in activities are also criteria for major depressive disorder. 4. Presence of either avoidance symptoms or numbing symptoms. DSM-5, 1 removed, 2 disqualify. 3 the symptoms must begin after the trauma. 4 require avoidance symptoms. Acute stress disorder. 1 fairly similar to those of PTSD but the duration is shorter. 2 symptoms occur between 3 days and 1 month after a trauma. 3 less is known about ASD. Most common disorders are other anxiety disorders, major depression, substance abuse, and conduct disorder. Two-thirds develop anxiety disorder. Women are twice as likely to develop PTSD. Culture may shape the risk for PTSD. Cultural groups may be exposed to higher rates of trauma and as a consequence manifest higher rates of PTSD. Etiology of trauma-related disorders. Severity and the type of trauma. Neurobiological factors. Greater activation of the amygdala. Diminished activation of the medial prefrontal cortex, smaller hippocampal volume, supersensitivity to cortisol. Coping. People who cope with the trauma by trying to avoid thinking about it are more likely than others to develop PTSD. Psychological treatment of PTSD exposure. The person is asked to face his or her worst fears, either direct, in vivo, or imaginal. More effective than medication. Cognitive therapy. Enhanced beliefs about coping abilities. Treatment of ASD may prevent PTSD. Shows benefits every 5 years after the traumatic event. Dissociative disorders and somatic symptom disorders. General characteristics of dissociative disorders. Sudden disruption in the continuity of consciousness, memory, identity. Some aspects of cognition or experience being inaccessible consciously. Avoidance response. Dissociative amnesia. Inability to recall important personal information, usually about the traumatic experience, not ordinary forgetting, not due to physical injury, may last hours or years. Deficits in explicit memory but not implicit memory. Explicit memory involves the conscious recall of experiences. Learning based on experiences that are not consciously recalled. Fugue, subtype of amnesia. Not only becomes totally amnesic but suddenly leaves home and work and assumes a new identity. May take on a new name, a new home, a new job, and even a new set of personality characteristics. Depersonalization, derealization disorder. Person's perception of the self or surroundings is disconcertingly and disruptively altered, usually triggered by stress. Depersonalization suddenly lose their sense of self. Derealization refers to the sensation that the world has become unreal. Depersonalization, derealization disorder, triggered by stress or traumatic event, no psychosis of loss of memory, often comorbid with anxiety, depression, and personality disorder, typical onset in adolescence, chronic course. Dissociative identity disorder, person have at least two separate personalities or alters, different models of being, thinking, feeling, and acting that exist independently of one another and that emerge at different times. Case reports have described alters who have different handedness, wear glasses with different prescriptions, like different foods, and have allergies to different substances. Typical onset in childhood, rarely diagnosed until adulthood. More severe than other dissociative disorders, recovery may be less complete. More common in women than men. Often comorbid with PTSD, MDD, borderline personality disorder, substance abuse phobias. No identified reports of DID or dissociative amnesia before 1800. Major increases rates since 1970s. Etiology of dissociative disorders, psychodynamic views. Dissociative disorders involve the massive use of repression, resulting in the splitting of from conscious of unacceptable impulses and painful memories, typically involving parental abuse. Dissociative amnesia may serve an adaptive function of disconnecting or dissociating one's conscious self from awareness of traumatic experiences or other sources of psychological pain or conflict. In dissociative amnesia, The ego protects itself from anxiety by blotting out disturbing memories or by dissociating threatening impulses of a sexual or aggressive nature. In dissociative identity disorder, people may express these unacceptable impulses through the development of alternate personalities. In depersonalization, people stand outside themselves, safely distanced from the emotional turmoil within. Social cognitive theory. Dissociation in the form of dissociative amnesia and fugue as a learned response involving the behavior of psychologically distancing oneself from disturbing memories or emotions. Dissociative identity disorder is a form of role playing acquired through observational learning and reinforcement. Biological contributions. There is some evidence of smaller hippocampal and amygdala volume in patients with DID compared with normals. Disruption in the normal sleep-wake cycle may result in intrusions of dreamlike experiences in the waking state that result in dissociative experiences. Diathesis stress model. People who are prone to fantasize are highly hypnotizable and are open to altered states of consciousness, may be more likely than others to develop dissociative experiences in the face of traumatic abuse. Post-traumatic model. Severe physical or sexual abuse during childhood sets the stage for DID. Sociocognitive model. Alters appear in response to suggestions by therapists, exposure to media reports of DID, or other cultural influences. DID could be created within therapy. Treatment for dissociative disorders. Therapy focuses on recalling what happened during the amnesic or fugue states, often with the help of friends or family who know what happened, so that patients can confront the information and integrate it into their conscious experience. For DID, reintegrating identities through long-term psychotherapy, hypnosis is often used to access unconscious memories and bring various alters into awareness and let the patient confront or relieve the early trauma. Somatic symptom disorders. Excessive concerns about physical symptoms or health. Physical symptoms that can either had or had no known physical cause. DSM-5 includes somatic symptoms regardless of whether they can be explained medically. Complex somatic symptom disorder. One or more somatic symptoms that are distressing or result in significant disruption in daily life, excessive anxiety, concern, or time and energy devoted to the somatic concern, and duration of at least 6 months. They experience their symptoms as completely physical. More emphasis on the distress and behavior accompanying somatic symptoms rather than the number of range of somatic symptoms. Illness anxiety disorder. Preoccupation with fears of having a serious disease despite having no significant somatic symptoms. Only diagnosed when a person has minimal or no somatic symptoms. Co-occurs with anxiety and mood disorders. Functional neurological disorder. Sudden development neurological symptoms. An illness related to neurological damage, but medical tests indicate that the bodily organs and nervous system are fine. People may experience partial or when a patient reports a neurological symptom, it is important to assess whether that symptom has a true neurological basis. Glove anesthesia, usually develop in adolescence or early adulthood, typically after a major life stressor. More women than men are given the diagnosis. More common among patients visiting neurology clinics, comorbidity, somatic symptom disorder, dissociative disorder, major depressive disorder, substance use disorders, and personality disorders. Malingering and factitious disorder. Malingering, a person intentionally fakes a symptom to avoid a responsibility. Factitious disorder. People intentionally produce physical symptoms or sometimes psychological ones to assume the role of a patient. Etiology: neurobiological factors that increase awareness of and distress over somatic symptoms. Pain and uncomfortable physical sensations such as heat, increased activity in regions of the brain called the anterior insula and the anterior cingulate. Cognitive behavioral factors that increase awareness of and distress over somatic symptoms. Once a somatic symptom develops, two cognitive variables appear important: attention to body sensations and interpretation of those sensations or attributions. People prone to worries about their health also demonstrate an attributional style that involves interpreting physical symptoms in the worst possible way. For example, one person might interpret a red blotch on the skin as a sign of cancer. The exact form of the cognitive bias may vary, but once these negative thoughts begin, the resultant elevations of anxiety and cortisol may exacerbate somatic symptoms and distress over those symptoms. The tendency to be overly concerned about one's health may have evolved from early experiences of medical symptoms or from family attitudes to physical illness. Treatment of somatic symptom disorders. Psychoanalysis seeks to uncover and bring into conscious awareness unconscious conflicts that originate in childhood. Once the conflict is aired and worked through, the symptom is no longer needed and should disappear. Behavioral approach focuses on removing sources of secondary reinforcement or secondary gain that may become connected with physical complaints. Cognitive behavioral therapy. The cognitive technique of restructuring distorted thinking helps clients identify and replace exaggerated illness-related beliefs with rational alternatives. The behavioral technique of exposure with response prevention. Mood disorders involving disabling disturbances in emotions from the extreme sadness and disengagement of depression to the extreme elation and irritability of mania. Two broad types. One involves only depressive symptoms. Two involves manic symptoms, bipolar disorder. Next, depression characterized by 1. Sadness, 2. Feelings of worthlessness and guilt, 3. Withdrawal from others, 4. Changes in sleep and appetite. Mania characterized by 1. Intense elation or irritability, 2. Hyperactivity, talkativeness, distractibility. Major depressive disorder involves a clinically significant change in functioning involving a range of depressive symptoms, including depressed mood, feeling sad, hopeless, or down in the dumps, and or loss of interest or pleasure in virtually all activities for a period of at least 2 weeks. Average number of episodes is 4. Episodic symptoms tend to dissipate over time. Subclinical depression, sadness plus 3 other symptoms for 10 days, significant impairments in functioning even though full diagnostic criteria are not met. Specifiers of major depressive disorder, psychotic features. Individuals in the midst of a major depressive or manic episode may experience psychotic symptoms, specifically hallucinations, seeing or hearing things that aren't there, and delusions. Mood incongruent, do not seem inconsistent with a depressed mood. Mood congruent, consistent with a depressed mood. Anxious distress specifier, the presence and severity of accompanying anxiety. Mixed features specifier, predominantly depressive episodes that have several, at least 3 symptoms of mania. Melancholic features specifier, the specifier applies only if the full criteria for a major depressive episode have been met, whether in the context of a persistent depressive disorder or not. Catatonic features specifiers. This serious condition involves an absence of movement, a stuporous state or catalepsy, in which the muscles are waxy and semi-rigid, so a patient's arms or legs remain in any position in which they are placed. A typical features specifier. Individuals with this specifier consistently oversleep and overeat during their depression and therefore gain weight. Peripartum onset specifier. Peri means surrounding, in this case, the period of time just before and just after the birth. The specifier can apply to both major depressive and manic episodes. Seasonal pattern specifier. It accompanies episodes that occur during certain seasons, for example, winter depression. Grief. Grief is characterized by a number of depressive symptoms as well as anxiety, emotional numbness, and denial due to death of a loved one. Can be considered normal as an initial reaction to the loss of loved one. Premenstrual dysphoric disorder, intended to apply to women who experience a range of significant psychological symptoms in the week before menses, and improvement beginning within a few days following the onset of menses. A range of symptoms need to be present to diagnose PMDD, including symptoms such as mood swings, sudden tearfulness or feelings of sadness, depressed mood or feelings of hopelessness, irritability or anger, feelings of anxiety, tension, being on edge, greater sensitivity to cues of rejection, and negative thoughts about oneself. Disruptive mood dysregulation disorder, severe recurrent temper outburst and persistent negative mood for at least 1 year beginning before age 10. Chronic depressive disorder, dysthymia, characterized by either chronic major depressive disorder or a chronic but milder form of depression, typically begins in childhood or adolescence and tends to follow a chronic course through adulthood. Depressed mood for most of the day, more than half of the time for 2 years or 1 year for children and adolescents. Double depression applies to those who have a major depressive episode superimposed on a longer standing dysthymia, have more severe depressive episodes than do people with major depression alone. Gender differences in depression. MDD, twice as common in women than men, similar discrepancy occurs in many countries. Differences emerge in adolescence, some biological and psychological factors such as hormones, girls twice as likely to experience sexual abuse, women more likely to experience chronic stressors, girls and women more likely to worry about body image, women may react more intensely to interpersonal loss, women spend more time ruminating, men tend to distract. Ruminating may intensify and prolong sad moods. Bipolar disorders. The proposed DSM-5 recognizes 3 forms of bipolar disorders: bipolar 1 disorder, bipolar 2 disorder, and cyclothymic disorder. Manic symptoms are the defining feature of each of these disorders, differentiated by how severe and long-lasting the manic symptoms are. These disorders are labeled bipolar because most people who experience mania will also experience depression during their lifetime. An episode of depression is not required for a diagnosis of bipolar 1, but it is required for a diagnosis of bipolar 2 disorder. Bipolar disorders 3 forms. Number 1, bipolar 1, at least one episode or mania or mixed episode. 2, bipolar 2, at least one major depressive episode with at least one episode of a hypomania. 3, cyclothymic disorder, cyclothymia, milder chronic form of bipolar disorder, lasts at least 2 years, numerous periods with hypomanic and depressive symptoms.